Hi, everyone. So here we are back again, and this is another topic that we're going to cover today with Dr. James Schaller out of Naples, Florida. He is a Lyme disease specialist. He's been treating patients for years and years and years. His website is listed on the Band-Aid Lyme website and also on this YouTube link. Now, the next topic we're going to cover today is treating pain in Lyme disease patients. And Dr. Schaller, why don't you take it away with this? What would you like to cover about this topic?
Well, right now, treating pain is like the politics right now in America. There are people that are Democrats that are very passionate. There are people that are Republicans that are very passionate. And I think everybody sees that intensity. That is exactly like people's opinion on the use of pain medications. Some are so opposed to it, other than a few days after you've had major surgery, that you just mention it, they go crazy. And I started my work in addictionology. I treated addicts full time for 2 years and worked in about 7 other addiction facilities during my training.
Wow.
I certainly respect and appreciate that some of these meds, opioids for pain, your body will get used to them, and you should be aware of that. But if you feel like somebody put a knife in your thigh, what are you going to do? Live like that for another year? I mean, you're non-functional. You can't work. You can't go to school. You can't take care of your kids. You're going to struggle to do everything. And don't think that you can fake it with the people around you. You're going to have a personality change when you're in that much pain.
Indeed.
But I want to mention a couple things before the powerful stuff. Generally, for example, in Florida, they like to see that you failed less intense pain meds. So let me just quickly mention a few. Tylenol, acetaminophen, and you can take 1,500 of that morning and night, and 1,000 milligrams in the middle of the day. And then there are many others in that group: aspirin, ibuprofen, naproxen, which is a leave. So you certainly want to try them at full doses. And let me give you an example of what a full dose is. If you're taking Motrin, ibuprofen, you can take 800 milligrams every 8 hours. And sometimes it works, but sometimes it doesn't. Then there are things like gabapentin, pregabalin, Lyrica, and at times they do help. So you may try them, and let's see if you're one of the ones that get benefit. Then there are a lot of creams and gels, etc., that occasionally are of use. For example, I use a ketamine 30% cream that is so powerful that if you had arthritis on your hand and put that cream on there, you could probably do mild surgery on the hand.
Wow.
Not the bottom of the hand, but right where that went in. And that is extremely powerful for nerves and muscles, etc., that are near the surface.
Okay.
Typically not good on the knees, hips, or shoulders, or back. The other thing is interventional pain medicine. At times they can be useful. That's typically an anesthesiologist. And what's the worst thing that happens? They give you something like a nerve block or one of the 10 other things they do, and it fails. And then then I think there are other things, but I'm going to get cracking. Uh, what do you do when all these things fail and you're not going to be very patient with significant pain? You probably were annoyed at everything I just said because you've already done most of these and you want to get down to the meat. You're not interested in salad. So just a few things on a handout that I published on Facebook. I have prescribed opioids for 31 years. And generally over time, we fix the cause of the pain. Now, usually not in a month, but eventually, which I realized last month and kind of surprised me. So you always want to be looking for other options and trying to figure out what's wrong.
Mm-hmm.
Sometimes it can't be fixed. Sometimes you need surgery, but you may not want surgery. So that's fine. The other thing is, it's recommended if you take an opioid, and some of them are quite strong, your pain is a 9 or a 10, and 10 is crying. And you take an opioid and you may go to 3. Well, you're an entirely different person out of 3. So if you are being given a strong opioid, they also should get you some Narcan, which if you make a mistake or whatever and take too much and you're not responsive, somebody just sprays it up your nostril. A few minutes later, if you're not up, they do it again, call 911. They're used to dealing with that, and things should be fine. But you don't want to have one can of Narcan that's somewhere in the garage behind the pictures from 20 years ago and canned goods that you got from your grandmother. No, when I write for Narcan, I write so many refills. So it's in their purse, it's in their pocket, it's in their car, it's in their bedroom, and I could go on. You get the message.
Okay.
Now,
can I back up and ask you a question as to why do people why are they usually coming to you or asking you for pain treatment medications in relation to Lyme disease and the related co-infections?
That's a great question, Valerie. I'm sort of surprised that people never come to me for pain control. They come to me for a number of other things that are mentioned on my website, personalconsult.com. And while I'm fixing those things, for example, mystery illness or Lyme, Babesia, Bartonella, abnormal hormones, you mentioned, you get it. I say to them, you really look miserable sitting here right now. And if they come with a relative, the relative's shaking their head. Yeah, Dr. J, you have no idea. He or she is in immense pain. So I'm the one mentioning, do you really want to live with that right now? And that's been very successful. So I've never had a drug seeker come to me.
So maybe some of the pain that I've seen in the Lyme and associated diseases community that people have in relation to having Lyme disease and these infections are degenerative disc disease conditions in the back, in the neck, in the lower lumbar region, and that causes them a lot of pain, nerve ending pain in different regions of the body, maybe even migraines or headaches. So can you elaborate a little bit more on the types of pain people have and where?
Well, I like the examples you gave, and it kind of relates to something that I think is very important. My patients have typically been referred to a ton of people, and they are turfed. I can't help you. Go find somebody else or go see that doctor. Nice to meet you. Have a good life. I never do that, but I definitely do strategic referrals. I am not good at evaluating what you should do with degenerative discs. I may be able to give substances which drop that pain from a 9 to maybe a 3 or 2, but I always want to make sure that the pain source is evaluated very precisely, not sending them for 20 things. We're sending them for 1, maybe 2 things. And then if it's a 10-minute appointment, you get something out of it. So that's one way we deal with it, is we use experts on that particular joint. Let's say you mentioned the shoulder. In my town, there's a couple amazing surgery experts, and have them look at it. And they may say, you know what, this is torn, or that ligament's hurting, or it's stretched, or it's ripping. I can't do that. I'm not waiting around in somebody's shoulder every other day. So no rejection, but let's use the experts only for what they're good in. So while we're treating the pain fully, we still are making sure they're getting the best medicine possible.
For the underlying infections also. And then if there's some type of surgery or something that might be necessary, that will be referred off to like an orthopedic surgeon, et cetera, et cetera. We know that Lyme and Bartonella, for example, love cartilage, that type of thing, and actually destroy cartilage. Unfortunately, that's not a laughing matter. I know Dr. Mosaieni, one of the experts on Bartonella as well. He's written some articles on degenerative conditions due to Bartonella. And so there's a lot of pain associated with those degenerative conditions in the hip areas, in the knees, in the back. And these are all conditions that do often result in very painful conditions eventually if the cartilage and these types of areas are destroyed, the discs, cartilage, et cetera, et cetera.
You're
So,
absolutely right. And I totally love Mosiani. He's amazing. He's great. I've consumed everything he's ever written and every word he said at least 5 times. I think you're totally right that these infections can get into the joints and cause catastrophic problems. 25% of Lyme patients, it's already in the joints very quickly.
yeah.
Actually, what surprises me is it's not more common than it is. So I do think part of treating Lyme, Babesia, and Bartonella, that may lower your pain, because they're drilling into tissue, they're in all the blood, so they're getting everywhere. So if you can lower that body load, you may also get a decrease in pain.
Mhm.
And then you may use a neurosurgeon or a spine orthopedist to give you a consult. Can we do anything for this? Well, maybe there's one disc we can do something to help. The other 2 we can't. Okay, that's fine. Yeah, the patient decides whether they want to do it or not.
Okay. So you manage the pain and then the treatment of the Lyme, Babesia, and Bartonella, and or the other infections, or Ehrlichia, Anaplasma, et cetera, et cetera. And then the other practitioners who are experts in spinal surgery or something like that will handle that type of thing. But
Well, the average patient coming to me does about 15 tick infection labs, and about 80 labs for large national laboratories. And those are split every 2 weeks over a month. So I am never just finding that it's Lyme, Babesia, and Bartonella and also give them pain. Typically, I'm finding 10 things that can be tuned. And so I'm doing all that. But yes, you're totally right. I may refer them to an interventional pain anesthesiologist. Maybe it works, maybe it doesn't. So you waste 90 minutes or 2 hours. And then you know you really need the pain med. So I think that's a little bit in a nutshell. There is one thing that pharmacists and other people worry about, and I think it's a reasonable concern. When you're on a pretty high pain med, but even on the lower side, and you take benzodiazepines like Valium or Klonopin or Xanax or Ativan, and there's a whole host, you got to be careful. And this is very common. I would say 70% of my pain patients are also on those because they have infections that ruin their sleep.
Right.
So it's always given with the warning that, there is a risk, but sleep is healing. The immune system gets better with sufficient sleep. And that's why many of us recall in high school or college, whatever, cramming and being up all night. I was the king of crammers. And then you feel sick the next day after the test. You lowered your ability to fight that infection by poor sleep. So I believe, and I do give benzodiazepines, anti-anxiety meds in a number of people. But there are other options like old antidepressants like amitriptyline or trazodone or doxepin, etc., that can also be tried first. And long-acting melatonin, you can go very high on that. And that does a number of good things for the body, particularly for women. So that would only be one thing that I make sure my patients understand, that is a risk.
There is some addictive tendencies associated with taking those medications, but in the same token, these medications may only be prescribed by you for a certain period of time, maybe a year, a couple years, however long, until the patient is actually over the hump of these really invasive infections in their body and their brain, and their toxin load of having these infections is lowered enough so that they can likely be weaned off at some point and returned back to some type of homeostasis.
Yeah, I think that's exactly right. So let's say, for example, I have somebody on oxycodone, maybe even 30 milligrams every 8 hours. Well, that's not a joke, that dose.
Yeah.
I really don't start that high. You'll totally snow them often. But what I'm seeing is the patient starts to forget a dose because they're not in the pain they had a year earlier. Well, then they say, well, I'm taking it twice a day. I don't want to be an addict, so I'll take it once a day. And they're okay with that. And then eventually they take a half, and then they take none. The other thing is, I wrote a book on something called Suboxone within weeks of the FDA approving it. It's a very large book, but it's revolutionized the treatment of opioid addiction. And so let's say somebody really is addicted to 10 milligrams 3 times a day, and they try to go down a little bit, and they feel restless and dysphoric. Suboxone is amazing. it's just a pill you take, and it decreases the cravings. So it's used in a lot of detox places, and I've been using it since it's been available, and it can be very useful. But I'm not finding I need to do that with my Lyme, Babesia, Bartonella patients. They seem to get better, and they seem to start saying, well, why don't we, I'll just take it once a week if I need it. It's really quite surprising to me. Never expected that.
So with the progression of healing, they seem to need these types of painkillers less, basically, is what you're saying.
Exactly. Thank you, Valerie.
Yeah. Well, that's a lot of good information, because perhaps people didn't know that these options were available for them to alleviate some of their suffering in relation to Lyme and these other infections. So that's good. That's good information. I've known a lot of people who have suffered greatly. I mean, especially with back problems, degenerative disc disease that has been brought on by Lyme and the other infections. I've known many people who have back stabilization surgeries. And it's really sad, because you know that they're really suffering and the discs are just worn away or gone or eaten away. And so I've seen it firsthand, people in wheelchairs, various clinics where I've been, some of my friends, unfortunately, and they're not necessarily in their 40s, they're maybe in their even late 20s, but they've had it for a very long time. So it's
Right.
good to know that these options are available for them. So thank you for that information, Dr. Schaller. Is there anything else you'd like to add to this particular discussion before we wrap?
Yeah, if I had a Christmas gift this year, and I have sent it to Santa Claus, it would be surgeons that are fixing joints with damaged cartilage or other things that aren't due to the fact they were an NFL football player and tore it when they were trying to take down a football, is they actually test for Lyme, Babesia, and Bartonella, because you don't want to have them coming back to see your friend who fixes knees. So that would be my appeal. If somebody wants to really treat me, besides Godiva chocolate, that is my other Christmas wish.
Okay, that's good information. Thank you, Dr. Schaller. So that will wrap our discussion on basically treating pain in Lyme patients. And in the future, we may delve into other aspects of this, but this is a presentation on this now, a delve into what kind of the parameters of what Dr. Schaller deals with and what he's seen in the clinical setting in his office with patients and even his own research. So thank you, Dr. Schaller, and we will move on to another topic just shortly. Thank you for sharing that great information with us.
Thank you so much, Valerie. You're the best. It's so much fun talking to you.
Thank you, Dr. Schaller.